Good evening, everyone. We're going to go ahead and get started. Welcome to this month's Coffee Convo at the Lurie Center for Autism. Tonight, we're going to have a jam-packed session on ADHD and autism. My name is Christina Sakai. I'm a developmental behavioral pediatrician at the Lurie Center, and presenting with me tonight.
I'm Nora Friedman. I'm a child, adolescent, and adult psychiatrist here at the Lurie Center.
Today's chat is going to be on ADHD. We want to cover several topic areas. What is ADHD? Everyone hears about it, but we'll get a little bit into the details of ADHD. How common is ADHD? How do you diagnose ADHD? What are common coexisting conditions with ADHD, including autism spectrum disorder? What are executive functioning skills? Why do they matter? And we'll go into the treatment recommendations, including the therapeutic behavioral approaches, as well as medications and pharmacological approaches. So what is ADHD? Well, ADHD is a neurodevelopmental disorder. It affects how the brain develops, and since brain development happens throughout childhood, symptoms begin during childhood, even though diagnosis may oftentimes be delayed and as late as adulthood. As a disorder, it significantly impairs social, academic, and/or work functioning. ADHD directly affects different parts of the brain. The blue area highlights the prefrontal cortex, which is responsible for things like organization, cognitive flexibility, self-control, and maintaining attention. This is like the manager or the CEO of a company. It's also the area that we term the prefrontal cortex is also the area for executive functioning skills. The limbic system is involved in controlling emotions, memory, and motivation. You might liken this to the human resource area of the brain. ADHD also affects the basal ganglia, which is the gatekeeper or the security guard of the company. It's responsible for motor control. It decides what actions to initiate and which ones to inhibit. Finally, the reticular activating system is also involved. This secretary of the brain relays information. It serves as the filter of the enormous amount of sensory information coming in from the environment. It decides what is important enough to be actually be brought to awareness. So all of these different parts of the brain are affected in ADHD. What ADHD is not. ADHD is not intentional or willful behavior on the part of the child or individual. That does not mean that they don't do things to manipulate the situation like everyone else. It is not laziness. It is not due to permissive or lax parenting. ADHD is not caused by diet, and there is limited evidence to support that it is improved with diet. It is not low intelligence or an inability to learn. ADHD is not only a childhood disorder, and in fact, we emphasize how ADHD is a lifelong disorder for many. ADHD is not unmanageable. With appropriate accommodations, behavioral strategies, learned skills, and oftentimes with medications, ADHD is very much a manageable disorder where individuals can and do thrive. ADHD presents as 4 different subtypes. ADHD predominantly inattentive subtype in the blue results in difficulty focusing, finishing tasks, and staying on target. There may be few or no symptoms of hyperactivity. ADHD hyperactive or impulsive subtype in the red often presents with difficulty sitting still or having quiet time. Individuals may interrupt others or act without thinking it through. They may show less obvious trouble with paying attention. Those with a combined presentation have many inattentive as well as hyperactive impulsive symptoms. And those with unspecified presentations may have severe symptoms that interfere with daily life, but symptoms do not meet the official criteria for the types listed above. I like to highlight how the presentation of ADHD can and does change throughout the years. Younger children may present with higher levels of hyperactivity and restlessness, yet the demands for attention are lower, and they may not exhibit any difficulties completing tasks and getting things done. As they get older, many times diagnosis might shift to a combined presentation, inclusive now of difficulties paying attention, or even an inattentive presentation whereby the person is less hyperactive, but demonstrates clear signs of inattention and distractibility. Because of these shifting presentations throughout the ages, the relative frequencies of each of these subtypes varies. But roughly about a third of individuals diagnosed with ADHD will be in each of the three main subtypes: inattentive, hyperactive impulsive, and combined. The following are lists of symptoms used in the diagnosis of ADHD. In the first list are symptoms consistent of inattention and distractibility. For diagnostic purposes, 6 or more of these symptoms, present often or very often, is indicative of an ADHD predominantly inattentive subtype diagnosis. The second list is hyperactivity impulsivity. And similarly, 6 or more symptoms present often or very often, or 5 or more symptoms in older adolescents and adults, because they're generally a little bit less hyperactive, are needed to make diagnosis of ADHD, predominantly hyperactive or impulsive subtype. If clinically significant symptoms are present in both of these categories, then a diagnosis of ADHD combined subtype is indicated. So everyone hears about ADHD, but just how common is it? The prevalence of ADHD varies based on which source one uses, suggesting great variability in the diagnosis of ADHD. This following figure and map is from the CDC National Survey of Child Health 2022. Parents were asked if their child was ever diagnosed with ADHD, and if so, whether they currently had ADHD. And you can see from the figure alone that these varied from 3% in some states to up to 15% in others. But roughly about 10% of children 3 to 17 years of age are diagnosed with ADHD. The majority are considered moderate or severe in impairment, and boys are 3 times more likely to be diagnosed with ADHD compared with girls, and racial ethnic differences exist in ADHD diagnostic rates. Now we're going to take a deeper look at ADHD and autism. The rates of co-occurrence vary, suggesting differences in diagnostic considerations. In clinical studies, where they might be actively looking for symptoms of co-occurrence, 53 to 78% of individuals with autism also meet clinical criteria with ADHD. Yet in community samples, only 28 to 31% of co-occurrence is noted, suggesting that the diagnostic rates in the community is less frequent in non-clinical studies. But why is there so much coexistence? Well, aside from that symptoms do overlap, there are genetic, environmental, and brain changes that explain the frequency of coexistence. In fact, there are many shared genetic risk factors between ADHD and autism. These disorders frequently co-occur in various members of the family. Functional MRI studies have shown that both share deficits in brain activation in areas related to attention. And as noted before, both commonly present with similar findings or similar symptomatology, including social difficulties, executive dysfunction, and language and/or cognitive impairments. So ADHD, or autism ADHD, is a term that has come from the neurodivergent community, recognizing that ADHD and autism can overlap and that they often coexist within the same person. Karam Sadiq is a neurodevelopmental psychiatrist specializing in autism and ADHD. He's the author of ADHD Explained, and he's a TEDx presenter, frequently presents, that summarizes his own personal experiences. My autism is my perseverance and grit. My ADHD is my fuel and creativity. And now, how do we diagnose ADHD? Well, ADHD can be challenging to diagnose. Oh, sorry. Let me see. ADHD can be challenging to diagnose in autism because there's compensatory mechanisms which may be used, thereby hiding the diagnosis or camouflaging the diagnosis. For example, a child who is using fidgets to compensate for restlessness may be able to sit still for some time rather than moving around, or an individual who in a one-to-one setting does really well with attention regulation, but has notable difficulties in environments where a lot of distractions are going on, maybe using compensatory mechanisms. Masking is when coexisting conditions exist and overshadow ADHD symptoms. For example, those with learning disabilities might have significant challenges completing assignments due to slower paces of processing or learning differences. Or those with anxiety disorders might exhibit higher levels of inattention or impulse control difficulties when they're nervous. Finally, autism and ADHD do have a lot of symptoms that can overlap, in particular around joint attention and repetitive behaviors, which might present similar to symptoms of inattention or hyperactivity of ADHD. Neuropsych testing here can be helpful to tease these out, whether there exist coexisting conditions or whether the individual is using compensatory mechanisms. I want to highlight, too, that attention is influenced by many things in the setting of autism. As mentioned before, joint attention, or social awareness and referencing, and social thinking, that is, orienting, understanding, and responding to intent of others, is oftentimes impaired in autism. Therefore, the individual may seem inattentive, but actually it is because of poor eye contact or difficulty with social referencing. Cognitive factors may also influence attention. Language is frequently impaired in autism spectrum disorder, and differences in comprehension and retention may result in appearance of inattentiveness. Cognitive differences such as slower processing speed or difficulties retaining things in memory, working memory, those also influence our attention. And additional executive functioning skills such as flexibility, shifting, and inhibitory control, those also influence our attention and appearance of attention. Arousal and emotional factors frequently do affect our children with autism or individuals with autism. Sensory components, either sensory stimulation, overstimulation, or needing sensory input for regulation, those affect attention. Our affect or our mood, anxiety, those also affect attention in autism. And then again, as mentioned, there is a high frequency of coexisting attentional disorders or ADHD, and that clearly affects attention and impulse control. Despite the benefits of neuropsych testing, it is not needed in the diagnosis of ADHD, even in the setting of autism spectrum disorder. We diagnose ADHD clinically by obtaining a detailed medical, developmental, and family history. Frequently, the symptoms have been present over some time, but may only later result in functional impairment or vice versa. There often is a significant family history of diagnosed or undiagnosed ADHD, and medical history is very important to rule out possible medical causes of attention difficulties, such as those that involve the thyroid or sleep disorders. Direct assessments include direct observation of the individual, report cards, standardized assessments of cognition, language, academic, and executive functioning skills. Finally, rating scales are used to obtain reports of ADHD-specific symptoms from parents or other observers. These also help us track or monitor symptoms with treatment. And rating scales are also important in eliciting coexisting disorders related to anxiety, mood, or other disruptive behaviors. So briefly on coexisting conditions. Symptoms of ADHD are really just the tip of the iceberg. Underneath, individuals with ADHD have difficulty organizing planning, low frustration level, difficulty learning from past experiences, impaired sense of time, difficulty prioritizing, memory deficits, some social difficulties as well. These may not be diagnosable conditions, but certainly they impair individuals' day-to-day functioning. This graph, however, highlights common coexisting psychiatric conditions in ADHD. And this is just ADHD alone, not ADHD and autism. But certainly both ADHD and autism can have these coexisting psychiatric conditions at higher frequencies. So each bar represents the frequency of coexisting ODD or oppositional defiance disorder, conduct disorder, anxiety, and mood disorders in ADHD. The white bars being those conditions alone, and the gray bars are those having more than one coexisting condition. So for example, in the first column, ODD, oppositional defiance disorder, occurs at a frequency of up to 33% of those with ADHD diagnosis, of which that in gray demonstrates a substantial amount of those also include other diagnostic considerations such as conduct disorder or an anxiety disorder or a mood disorder. In addition, I want to highlight that ADHD frequently coexists with other neurodevelopmental disorders. Learning disabilities is very common. 30 to 50% of individuals with ADHD have learning disabilities. Language impairment is also pretty common. Autism spectrum disorder, common. Developmental coordination disorder, also very common. So difficulties with motor planning and coordination. Want to kind of comment a little bit extra on executive functioning skills. So executive functioning skills include impulse control, self-monitoring, flexibility, shifting, emotional control, task initiation, planning, organizing, time management, working memory, and attentional control. I usually describe skills as something that we can work on and that take effort and practice to develop. These skills are developmentally based, so they progress over time and age. We cannot expect a toddler to have good impulse control, and maybe not even a teenager who is excited or influenced by a peer. But we would hope that by adulthood, that individual has gained skills which can help with impulse control. These boss skills or executive functioning skills, right, are oftentimes impaired in the setting of ADHD and autism kind of separately, and also ADHD autism together, and they take longer to develop than would typically be expected. Executive functioning skills are not improved on medication for ADHD specifically. However, medications can allow for increased attention, improved impulsivity, which then helps individuals carry out and gain executive functioning skills when consistently taught and supported. While I hope that this talk so far has given us a better understanding of what ADHD is and how it is diagnosed, what I'm really interested in is what do we do about it? So I'm going to pass the baton to my colleague and co-presenter tonight, Dr. Nora Friedman, who will discuss therapeutic interventions.
Thank you, Dr. Sakai. So when we're thinking about treatment options, it's helpful to begin with non-medication interventions. Those are also called non-pharmacologic or psychosocial interventions and include options like therapeutic and behavioral supports. We always want to begin by understanding a person's strengths and challenges so that we can identify the right resources and implement the right supports to best meet their needs and be of help. And we want to think about operating in a range of domains. So ADHD, the impairment has to impact functioning across settings and in different areas of a person's life. So at home, at school, or at work, out in the community. And therefore, we're going to have an array of supports that are going to be relevant to all of those different facets of someone's life. So first, we should talk about the format for therapeutic and behavioral supports, right? It could be directed at the individual themselves. It could involve parent or family members, could take place in group formats. And the settings for these interventions are varied. It could be at home, out at schools, or in work and vocational sites, in outpatient clinics, in the community, and of course, also online. Next slide. So what are the targets for our treatment? We have, first and foremost, we want to start with psychoeducation. And that's the idea of providing patients and their families with information about autism and ADHD, helping them to understand how to manage symptoms, explaining treatment options, and available resources. As Dr. Sakai mentioned, executive functioning is a very important piece of the clinical picture here and often a very interfering aspect for individuals with autism and with ADHD. And so that can be a very important target for our interventions. You can see emotional and behavioral regulation, both for individuals with autism alone, for individuals with ADHD alone, and for individuals who have both of those conditions. And so that is something that we often find ourselves needing to address. Social skills, again, we can see deficits, of course, with autism, but also for patients with ADHD alone. And we have some helpful interventions to target social skill development. And I also wanted to mention behavioral parent training. These are specific programs based on principles of behavioral science that try to help families and parents, in particular caregivers, develop more effective ways of interacting and communicating with their children, to promote positive behaviors and to discourage negative ones. And the way that parent behavior training programs operate is through helping families develop appropriate strategies, so learning to provide praise or other positive reinforcement strategies to encourage desirable behaviors, and creating clear and consistent consequences for undesirable behaviors. There is a really strong evidence base for behavior parent training in ADHD. It's also been studied in autism. And I've listed a few of the formal structured behavior parent training programs like parent-child interaction therapy, parent management training, and the positive parenting program. Next slide. So we have our therapeutic and behavioral supports, and then we also want to think about environmental modifications. So how can we intervene in the environments in which a person operates to help them be more successful? Many patients with autism and with ADHD are going to benefit from having consistent structure, clear routines, and so that's something that we can put in place across the different settings. There are also sensory strategies that can be very helpful. So giving patients access to fidgets, chairs that rock, or standing desks in school or work settings, recognizing that some individuals will have sensitivity to things like lighting and sound. So keeping the lights low, providing access to noise canceling headphones can all potentially be helpful. We also have movement breaks that can be particularly helpful for individuals with a lot of hyperactivity and impulsivity who can sort of focus for discrete periods of time and then find it beneficial to stand up and move around or engage in some sort of sensory, maybe spinning, jumping, swinging, whatever it might be, to sort of settle themselves and then come back to the work at hand. In classrooms, we'll see things like preferential seating, having kids not directly in front of a window where they might get distracted by what's going on around them. Sometimes students will benefit from having extended time for assignments and tests. And there's also an array of executive function tools that can be helpful. So these include things like checklists, planners, timers, alerts, and of course, the good old-fashioned behavior chart. I also wanted to highlight exercise. There is evidence that suggests that exercise can be helpful for ADHD. The research suggests that cardio seems to have more benefit than non-cardio, but this can be a very sort of helpful intervention for families and other caregivers to provide. Next slide. So I want to just take a moment to highlight a few important points as we're thinking about putting together a range of supports for an individual with autism and ADHD. The first is the need for coordination across settings. So to the extent that we can have consistent expectations and responses to behavior at home, at school, at day programs, out in the community, that can help affect positive change and provide structure that will be helpful to the individual. Autism is a range of different features. So we have individuals who span the spectrum in terms of their social communication skills, their cognitive functioning, their ability to regulate their mood and behavior. And therefore, the array of supports that we can choose from will come up with a specific menu for a given individual. There are going to definitely be some overall strategies that can be helpful for many patients. But we also recognize that a certain person might benefit from one intervention and not another. And so we're constantly assessing and making sure that we're providing the right range of supports for that particular person. And this brings us to the important part about developmental stages, right? As a child matures and enters
Apologize.
and adulthood, their needs may very well change. And I like to think about the school journey. So when students transition into middle school, there's often an increase in executive function demands. Suddenly, they may be moving between classes, having different teachers and different sets of classroom rules and expectations and demands from the various staff that they're now working with. And that can be a very big change for them. Similarly, when they enter high school, the workload may increase, as will the executive function demands. Or if they transition to higher education and they're living on campus, now they're no longer just managing the academic demands. They also have to figure out when to do their laundry, how to get to the grocery store, how to complete the administrative paperwork. So that can be a really significant transition point for people. Or if they're moving into vocational or work settings where suddenly they have to deal with the interpersonal demands as well as organizational and time management pieces. So it's helpful to always be sort of reassessing what we can be doing to best support an individual as they are progressing and their specific context and environments may change. Next slide. I wanted to take a moment to also talk about digital therapeutics. Some of you may have heard about these software-based products that target specific cognitive skills like attention. One of them is known as EndeavorRx. It's a video game treatment. It's been authorized by the Food and Drug Administration, the FDA. It does require a prescription, and it is approved for the use in children ages 8 to 17 with ADHD. And the usual schedule is to play 25 minutes a day, 5 days a week for at least 4 weeks. EndeavorRx was studied in 5 studies of more than 600 children. There is also an adult over-the-counter version known as Endeavor OTC. It does not require a prescription. And this is geared for adults ages 18 or older who have primarily inattentive or combined ADHD. Next slide. So there is a set of guidelines that was published by the American Academy of Pediatrics in 2019. And they did a review of sort of diagnosing and treatment of ADHD. And I did want to call attention to those interventions that they say lack insufficient, lack evidence or have negative evidence to support their use. And that includes mindfulness, cognitive training, dietary changes, EEG biofeedback, supportive counseling, and something that's called external trigeminal nerve stimulation, which is also an FDA cleared device, but it was based on a very small study of 30 subjects. And because of that, the AAP does not recommend its use at this time. So now we'll move on to medications. And I want to start by explaining some general principles that I think about as a clinician before I will prescribe medications. So the first is to assess for any potential medical causes or environmental factors that may be contributing. And Dr. Sakai referenced this. When you have someone coming in who, let's say, is exhibiting a high level of hyperactivity or impulsivity, we want to make sure that we're not missing something physical that could be contributing to their presentation. Especially if there's a sort of acute or semi-acute onset of those symptoms. Is there ear pain or dental pain, something that's kind of driving this dysregulated behavior? We also want to think about environmental factors. Is this a child who's in an incredibly overstimulating environment that's making it even harder for that child to be able to focus and attend to what's been going on? And so to whatever extent that we can modify the environment, to whatever extent we can rule out any potential medical or physical issues, that already puts us on a stronger foundation for then thinking about the role that medications can play. In patients with autism, it's always advisable to start low and to adjust the dose slowly so that we can monitor for any side effects or adverse responses. In general, unless we're hard-pressed to do something otherwise, it's always a good idea to make one medication change at a time. Otherwise, we run the risk of, let's say, increasing a drug and starting a new one at the same time, and then the child doesn't tolerate it, and we don't know what caused it. Was it the increase in the first medication or the addition of the second? So doing things stepwise will help us to be able to determine whether something is helpful or having a negative impact. It's always good to think about medications that might have what I think of as desired side effects. So maybe there's a medication that also makes people sleepy, and that can be particularly helpful for a patient who has ADHD, but also experiences insomnia. And I'll share more about that in a few slides. We're going to always monitor for adverse effects, and we're going to continually assess for the risk-benefit ratio of a given drug. Whenever we have opportunities to think about reducing or potentially discontinuing a medication, we'll certainly explore those because we want to try to use the lowest possible dose without causing a patient's symptoms to destabilize. So I've listed 3 of the main classes of medications that have approval from the FDA for the treatment of ADHD. So we have stimulants, which include amphetamine and methylphenidate preparations, alpha agonists, which are medications called clonidine and guanfacine, and finally norepinephrine reuptake inhibitors, or atomoxetine or viloxazine. Some of these drugs, like methylphenidate, extended release guanfacine, atomoxetine, they have been studied specifically in patients with ASD, but others, like amphetamine and viloxazine, have no published trials in the ASD population. So, as clinicians, we're often pulling from the general evidence base for treatment of ADHD and then using clinical experience to help guide our decision making. And some patients may require a combination of medication, so they might need a stimulant as well as an alpha agonist. In terms of side effect profiles, I've listed some of the common as well as some of the rare but notable side effects. So as you're reading through these, I won't go through all of them, just know that some of them here are thankfully quite rare, but I think important for families to know about. So stimulants can impact sleep. They might be associated with headaches or stomach aches. They do have effects on the cardiovascular system, as does atomoxetine. So we can see increased pulse and blood pressure. They are sort of notorious for reducing appetite and can also lead to a decreased growth velocity. And sometimes patients will experience moodiness or irritability. This can be because the dose is too high, or sometimes families will report that that happens as the medication is wearing off, sort of towards the end of the day. For the alpha agonists, they can cause drowsiness and sedation. This is more common with clonidine than guanfacine. We can also see things like headaches and dizziness, dry mouth. They actually have an anti-hypertensive effect. So unlike stimulants, they decrease pulse and blood pressure. And in some patients, they can cause or exacerbate constipation, which is something that is often important in our patient population. Atomoxetine can cause fatigue, headaches, and stomach aches. It can also have effects of growth. Usually, the data suggests that's in the first 1 to 2 years of treatment. I mentioned the elevated pulse and blood pressure. And finally, it can rarely be associated with liver injury. And both atomoxetine and viloxazine have a black box warning from the FDA about the risk of suicidality for patients who are prescribed these medications. So that's something that we will monitor closely as families, caregivers, and clinicians to make sure that we don't see any of those emerging symptoms. Viloxazine can also be associated with fatigue, insomnia, some GI symptoms like nausea, vomiting, reduced appetite, as well as increased blood pressure and pulse. And it can also see potentially activation of hypomanic or manic symptoms. Atomoxetine and viloxazine are chemically more similar to antidepressants, and that's a risk that we see with antidepressants generally, and we can also see it with viloxazine. So in terms of medication selection, we have thankfully really an array of options available to us. The ADHD meds have been well researched, and thankfully we really have a very full armamentarium to choose from. When we're picking a medication, we want to think about the duration of action. Do we need a medication that has an immediate release, Or do we want one that has a longer duration of action? So maybe it's a medication that can be taken once a day, but has its effectiveness over the course of the school day or the work day. There are different routes of administration. Obviously, we have lots of oral medications, but for some patients, if they're not able to tolerate that, they might do well with a transdermal or a patch that's based on the skin. We have those both for methylphenidate products, and there's also a clonidine patch. And we also want to think about the method of administration. This is particularly pertinent for patients with autism who can have sensory issues and have difficulty swallowing tablets and capsules. So if someone is not able to swallow a tablet or capsule whole, there are some formulations that include crushed or chewable tablets, capsules that you can open up and sprinkle into applesauce or yogurt. And we also have some liquid preparations. And I also just wanted to make one comment, which is that some of these medications will take effect much quicker than others. So with stimulants, you'll see right away whether they're helpful or causing problems. Medications like atomoxetine and viloxazine, it can actually take a few weeks to see the full therapeutic effect at a given dose. So it does require more patience. Now, how do we think about medication selection? So stimulants are the first line pharmacological treatment option for ADHD in patients without autism. But in our patient population, in individuals with autism and ADHD, non-stimulants, so either the alpha agonists or atomoxetine or viloxazine, may be more suitable depending on their specific clinical profile. And I wanted to sort of highlight some of the reasons why we might choose specific medications first. So if we have someone who has a high degree of behavioral and emotional dysregulation, we might want to start with something like clonidine or guanfacine. If a patient experiences sleep difficulties, we might want to avoid a stimulant which can contribute to initial insomnia and use something like clonidine, which can be sedating. There is labeling from the FDA on stimulants, warning that they can be associated with the onset or worsening of tics. However, this was not substantiated in a meta-analysis that came out about a decade ago in 2015. Nonetheless, for patients who have ADHD and co-occurring tic disorders, an alpha agonist may be preferred, and that's because clonidine and guanfacine are actually first-line agents for the treatment of tic disorders. So we're sort of constantly thinking about what are the different symptoms that we need to target, and can we address more than one problem at the same time with one drug? Finally, for anxiety, we might want to think about things like atomoxetine or viloxazine, which should be neutral or have a mild benefit on anxiety. And I also just wanted to point, or something that you might come across online or in your reading, is that there was earlier research that suggested that patients with autism did not tolerate stimulants as well, and the efficacy of stimulants was decreased in that population. And in fact, that has not been substantiated by subsequent research. There was a 2022 study that showed there was no difference in treatment effect or rates of adverse events between patients who had a high level of ASD symptoms and patients with a low level of ASD symptoms. So our understanding of how the ASD patients respond to these medications continues to evolve. And now we would love to open it up for questions. Feel free to unmute or type your questions into the chat. I see somebody with their hand up, JM, and yes, please go ahead.
Hi there. I was curious, you mentioned earlier in the presentation that pharmaceuticals won't address executive function skill deficits. Are there any recommendations you have for helping ADHD children sort of develop those skills?
Sure. Yeah, I mean, I think that's a really important point. And as Dr. Sakai noted, that by treating ADHD, right, helping children to be able to focus, it may be that their capacity to absorb information and utilize skills can be increased. And there is specific executive functioning coaching. So that can, again, take place in a variety of formats. It could be a school-based intervention, it could be out in the community or an outpatient clinic. But these are specific strategies for helping individuals develop organizational skills, time management, inhibitory control. And so usually that sort of focused executive functioning intervention can be very helpful. So I'm just looking through. Are there training programs for adult caregivers? It's an excellent question. So I talked about the parent behavior training, which have mostly been studied in younger children. Some of them have been studied in adolescents. Uh, but that is a wonderful question. And I don't know if there are any specific formal programs for adult caregivers, but I do believe that a lot of the strategies for supporting a loved one with ADHD and helping to address the executive function difficulties can be applied across the ages. And, just getting some support around how to help build in organizational support or to encourage routine and structure, those are going to be applicable usually across the age spectrum. Continue going through the chat. What age do you typically start trying medications? Is 5 years too young? So, Dr. Sakai, I don't know if you want to weigh in as the developmental pediatrician, and then I could share my thoughts.
Yeah, absolutely. So there's not a set age that is too young either for the diagnosis of ADHD, nor for necessarily for medication treatment and intervention. We do really heavily focus on ensuring that there's behavioral strategies and accommodations that are in place, especially for the younger ones. Because sometimes there is an increased tendency for some side effects with the younger children on medications. However, there is not a set age, and there's definitely a lot of 5-year-olds with autism ADHD that are on medications. Going on to the next question, what about naturalistic options instead of medications such as B12, magnesium, etc.? And I might just jump in and make a mention that frequently do encourage a good vitamin supplementation of these micronutrients because a lot of kids with autism are a little deficient. They have a little bit of a restricted diet. There are a lot of a restricted diet. However, when it looks at research as a whole, these supplementation with B12, magnesium, zinc, omega-3, none of those actually make a significant difference with ADHD and attention. And then, sorry, there's another question about the increased diagnosis of women with autism spectrum disorder and asking if that's the same true with ADHD. Definitely in recognition of the different clinical symptoms and presentations of women, girls with autism spectrum disorder. And similarly with ADHD, because it's becoming more recognized or more of a term. I think there's more attention and awareness of that. So there's probably an increased diagnosis of individuals with both autism and ADHD. I'm going to let Dr. Friedman answer the 6-year-old question.
So, this is a question about a 6-year-old with an ASD diagnosis where there is a suspicion of an ADHD as well, but it sounds like it has not yet been formally diagnosed, and a question of whether would be advisable to formalize the ADHD diagnosis before starting a medication like guanfacine? That's a great question. I mean, I think to Dr. Sakai's point, you do not need formal neuropsychological testing to make an ADHD diagnosis. The comprehensive neuropsychological testing can be very helpful for understanding a patient's full neurocognitive profile and their emotional, functioning and their social functioning. But again, ADHD is a clinical diagnosis, and my sense is that it should not be hopefully too onerous to kind of get the information you need to decide whether or not this child meets criteria for ADHD. With that said, we will use guanfacine not just to treat ADHD, but sometimes to treat a lot of really impulsive dysregulation in patients with autism. So patients who, get tend to fly off the handle or can get very physical or agitated. Sometimes guanfacine can be a helpful medication. And so I would say if there are enough issues or challenges that are pointing you to starting medication, then, it's okay to try it. And also, I think at the same time, try to clarify the ADHD diagnosis. But things are never completely clear cut in some of the patients that we work with, and we often are treating symptoms and the things that are impairing and getting in the way of functioning, even if the diagnostic picture is not always clear. So I hope that's helpful. And then somebody asked, would you avoid stimulants for a young child because of the side effects on growth and appetite? It's such a wonderful question. Again, stimulants are the first line treatment in neurotypical patients with ADHD. So certainly many children are treated with stimulants. I think this is a personal decision for families and for patients if they're able to weigh in on the matter. Yes, we know that it does decrease growth velocity. Often this does not translate to a clinically significant change in the sort of adult height obtained. But I think for some families that might be worrisome enough that they might think about starting other medications first before moving to a stimulant. It's similarly, many patients on the spectrum have very restricted dietary preferences, very limited intake of foods that they'll eat. And so if they're going to experience further appetite suppression on a stimulant, which can impact weight gain, that might be a deal breaker, and they're going to be better suited to starting with something else, a non-stimulant. Do you start with a stimulant then in a patient with a comorbid ADHD and ASD, given the meta-analysis? If no, other specific comorbidities? I hope I'm understanding this question. What I would say is that for me, it's really looking at, again, the different symptom clusters that are interfering. And if I'm seeing it's ADHD plus something else that I know is going to be better treated with something like clonidine or guanfacine, I'll start with clonidine or guanfacine. Or if there's some really strong reason why I don't want to start a stimulant. So a child with a very, very picky eating, who's already underweight, and I'm just worried about the appetite suppression and potential weight issues with stimulants, then I might shift to something different. But, as far as we can pull from the guidelines, from the general pediatric population, starting with the stimulant is the first line option. Dr. Sakai, do you want to take over?
I might jump in a little bit on the ADHD kind of questions. One on ADHD and PDA, which is pathologic demand avoidance presentation, and whether there are studies specifically being done on this population. Not to my knowledge. I think these are newer kind of terminologies that are being recognized and understand to describe these broader kind of clinical symptoms or symptoms that are presenting. Here, I would probably say that kind of similar to the next, a little bit further down, can you speak about how ABA helps or does not help with ADHD? I'll kind of mention this. ABA is an essential intervention in therapeutic service for establishing initial joint attention, those foundational skills in joint attention, as well as those foundational skills in communication. So I have found that consistently young children who are very inattentive and very distractible, okay, when they have ABA interventions, their joint attention is significantly improved. So ABA can be very, very, very beneficial in those settings. ABA is also very helpful for establishing functional adaptive skills, toileting. It's very helpful for kind of setting boundaries and safety. It can be helpful for sort of establishing and understanding problematic behaviors and how to respond and address them. ABA is probably a lot less helpful in addressing things like executive functioning skills or social thinking, social referencing. It's a lot less helpful in those type of interventions and areas. And I think when you do have ADHD on top of the autism spectrum disorder, it can also be helpful to have the structure of ABA, but it makes it that much more challenging in times to be able to engage consistently with therapy. So therefore you have individuals that are more distracted. I do think that it is exceptionally hard. There's this kind of comment on finding executive function executive functioning skills, it is very exceptionally hard. So having occupational therapy is very helpful. I think occupational therapy can be very, very helpful, again, for those sensory regulation needs and for regulation in general. So some occupational therapists can really help to recognize where's my level? Am I dysregulated? Am I starting to get dysregulated? And what can I do about that? But when it comes to core executive functioning skills, flexibility, planning, organizing, time management, those can be very challenging to obtain. And unfortunately, there's probably not a lot of easy access to these kind of interventions. There's books, there's websites, there's programs I happen to like. Unstuck and On Target as a resource. I think Social Thinking Boston also has a lot of resources around executive functioning skills and social skills that oftentimes could be tapped into and utilized.
Great. There have been so many coming in. I'm trying not to miss any, but just seeing some about the pros and cons of allowing a child to have a day off of medication on the weekend. I think this was a strategy that was very popular in part because of the impact on appetite and weight that we sometimes saw with stimulants, and families felt by giving their child a couple days off, then their child could sort of rebound, eat better, and then go back onto the stimulant for the weekends, or maybe the demands on the weekends just didn't require ADHD medication. That is not as great an option for medications that need to build up over time. So atomoxetine, viloxazine, if you're stopping it on the weekends, you're kind of negating the benefits of the medication. And I would also say that as patients age, the demands on the weekends actually probably become more significant. So if they're in high school or secondary school or in a vocational setting and they need to be productive and on task during the weekends, or they're participating in youth sports, it might be really hard for them to not be on a stimulant or their ADHD med on the weekend. So it's really a very personal decision. And I think it's about considering what is it that they need to do on Saturdays and Sundays. Are they able to do that well and effectively without medication? If so, great. And if not, then I advise families to try to give it consistently, even on weekends or school vacations, whatever it might be. Somebody asks if guanfacine can be expected to completely help with behavioral issues and impulsivity if it only helps somewhat or stimulants the next thing to try. Yeah, some patients will have a great response to clonidine and guanfacine and might see really marked improvement. But certainly in the patient population we see at the Lurie Center, we often do need to use combination therapy. And so it's a popular combination to be on a stimulant as well as an alpha agonist. So sometimes adding a low dose of a stimulant can be helpful, or thinking about other options. And then somebody mentions developing a chronic cough, a vocal tic on Adderall and Concerta. And again, that's probably somebody, if the timing, it's tricky because the onset of tics often correlates with when kids come to clinical attention for ADHD symptoms. And so there's been a lot of interest in whether stimulants worsen tics or do they not. And we can't confuse correlation, which is that two things happen at the same time, as causation. So X causes Y. But in a child who has developed tics or an adult who's developed tics, and it's not difficult potentially to stop the stimulants and to start something like clonidine or guanfacine, which will hopefully not only treat the ADHD symptoms, but can also be a great treatment option for the tics. Let's see. There is some questions about the PDA presentation. Are there new studies being done for this population? So pathological demand avoidance is extreme resistance to even ordinary demands. And I think for a lot of families, when they read about the PDA profile, it really seems to resonate with them. It helps to explain the challenges that they have seen with their child or family member. It's important to point out that it is not a recognized diagnosis in the Diagnostic and Statistical Manual, or the DSM-5, which is the diagnostic manual we use. It's also not recognized in the international equivalent, which is called the ICD. It's a term that originated in the 1980s, came from a researcher based in the UK. And so there are some really interesting and potentially helpful resources online coming from organizations like the PDA Society in the UK. So I think for some families, again, this can be a very helpful way of conceptualizing the challenges that their loved one is experiencing. But I can't speak to specific research at this point with that population. I'm just not aware of it. That doesn't mean it's not happening because I do think it's an area of great interest for clinicians and also for families.
We have time for probably just one more question.
Sure. Dr. Sakai, do you want to take the last one?
Absolutely. So I'm going to actually, I'm also trying to answer some of the questions on your chat that we haven't been able to get to verbally. But I believe the last question, can you outgrow, lose an ADHD diagnosis, or is it a life sentence? Okay, I'll answer that one. Thank you. It's a good note to kind of end on. I do recognize that ADHD and autism, they are considered lifespan disorders and diagnoses. So we don't necessarily lose them or grow out of them, but we can develop very good skills and strategies to manage them and thrive despite having autism or despite having ADHD or despite having autism ADHD together. And in fact, as I kind of mentioned, the quote that was given, it really reflects that individuals can take those unique strengths in each one of those diagnoses and actually do quite well. So what we work on with intervention is not necessarily to cure the disorder or get rid of the disorder, but it's really to develop the skills and the strategies and learn how to manage those disorders.